I'm Dr. Jelaine Bullock-Berquist, social media editor for Seminars in Arthritis and Rheumatism. Today I am speaking to Dr. Jasvinder Singh about his article, Rituximab is associated with worse COVID-19 outcomes in patients with rheumatoid arthritis. This is available online, open access, in the February 2023 issue. Please continue to watch for details regarding the study. Thank you for joining me today, and congratulations on your study. This is obviously very important work as we try to understand more about our rheumatoid arthritis patients face during the current pandemic. Can you tell me a little bit, Dr. Singh, about what made you interested in doing this particular study?
Yeah, so thanks for the invitation to share some of our thoughts about this work. What really motivated our team to look into this question was emerging data from several studies, some from Europe, and a couple of single center studies from within North America that had indicated that rituximab may in fact be a risk factor in terms of COVID-19 infection risk and perhaps some other outcomes. However, the data from these studies were contradictory sometimes. The sample sizes were small. Most were single center, if not all. Even the studies that were done with some of the national databases were from small European countries. And given the differences in the pandemic and how it panned out across the globe and the types of treatments available, we thought it was important to do a study within the U.S. to understand, what impact does this have for our own patients. So that's what really motivated us to join the N3C consortium, which is a national consortium through the CTSA centers funded by National Institutes of Health throughout the country that put together an effort for various CTSA sites to pull data from a lot of these healthcare systems and to harmonize it into a repository and then to make that data available for people to do real-time COVID studies.
Nice. And can you go through for us the methodology as well as your results?
Sure. So this study, as I indicated, uses the N3C consortium data, which is a national COVID Cohort Collaborative. It is the largest U.S. cohort of COVID-19 cases and controls to date. We use that to identify people with rheumatoid arthritis using the ICD-10 code. And then we focused on baseline use of rituximab prior to a COVID infection as a main exposure of interest. The N3C collaborative has data on COVID infections, more than 95% of which is based on the PCR. We abstracted patient demographics, other clinical characteristics, smoking, body mass index, US region, and other comorbidities such as using the Deo-Charlson comorbidity score. We also accounted for COVID-19 treatments themselves because as much as the infection itself is not impacted, the downstream outcomes which we're really interested in with regards to hospitalization, mortality, as well as other outcomes of importance, we really needed to account for COVID treatment. So there are certain aspects of our study that are quite unique and are important because, as you can imagine, the use of these treatments that has evolved over time impacts COVID outcomes. Use of vaccines impacts COVID outcomes. The studies of COVID outcomes done in rheumatology that tend to ignore these and just look at a disease or are in medications, it's completely ignoring things that have far more impact on COVID-19 outcomes than anything else in the world would. So the true strength of the N3C is looking at the downstream outcomes because they're not dependent on how the sampling is done. The sampling, and therefore the COVID-19 infection rate is an outcome that we collect, but we focus on downstream outcomes, which in our, clinically speaking, were far more critical in our view. So from a total of about 69,549 patients who met the eligibility criteria, 22,956 actually had COVID-19 positive diagnosis in the period between 2020 and 2021. And out of these patients with rheumatoid arthritis who were COVID positive, 364 had been exposed to rituximab. And when we look at the comparator of using a conventional synthetic DMARD such as methotrexate or others, we found that rituximab use was associated with higher odds of COVID-19 related hospitalization to almost doubling of the risk. ICU admission risk was fivefold, and invasive ventilation risk was about threefold. We also had looked at some other outcomes, such as acute kidney injury, ICU length of stay, and hospital length of stay, and we did not find differences in those outcomes.
So last question, will this study change your practice of rheumatology, especially knowing now what we know about Evusheld and potential resistance against Omicron variants of COVID-19? So our resources for taking care of these patients and preventing severe outcomes are getting more limited. So does this change what you do with your rheumatology patients? I
think that practice of being very cautious with the use of rituximab, even in 2020, 2021, this study supports that. Now, we are not in 2021 anymore. We are in 2023, and there are new treatments and there are new strains. So first, we actually need an updated study that accounts not only for these things, but accounts for the COVID-19 vaccination, the completion of COVID-19 vaccination, the number of boosters, the time period between boosters, the time the last booster was done, and the proximity of last booster to the last rituximab dose. So you can imagine that we really, in 2023, in addition to the study that we have right now, we actually need an updated data and analysis that accounts for the current way that people are treating and using preventive measures for COVID, and also just for the current COVID-19 treatments, including Evusheld. Yeah. Because there's the other issue with Evusheld is that you can minimize and actually reduce symptoms effectively. However, some patients have rebound symptoms and resurgence of COVID as well. And whether that is even an exaggerated or a more amplified phenomenon of the rituximab, we don't know for sure. We also tried to look for time since rituximab infusion, but because we were only an 18-month data source at that time, nationally, we still only could have 384 patients. So you can imagine we might have doubled that sample size now, but we are going to bring in another 8 or 9 clinical factors, including all the vaccination combinations and the new treatments. So we may still have issues even with doubling of sample size. We'll still have issues with power, even in a national study. Having said that, we need to do that study to understand what it is that is happening with our patients so that we can make more informed decision in the next 6 months to next 2 years. What I would do today, or what I do today based on what we know and what we don't know, and there's probably more that we don't know. And I think I've tried to explain that in my response to you, that as much as this and other studies help us, we really need a lot of real contemporary, real-time, updated data analysis that is representative and can inform practice. Because that sort of analysis can tell us, can we time our rituximab infusions? And should that be only done in people who have had 2 full series of 2 vaccine and 3 boosters as recommended by the CDC? And in those cases, what factors, who are our high-risk patients? Can we have a shared decision-making with those patients? Say, okay, I need to give you rituximab, but because of your male sex and CAD and cardiovascular risk factors, and the fact you only took one booster and you're not going to take the other two because you don't believe in it or you're sick and tired of it, your risk with rituximab for bad COVID outcome is X. So in other words, I think that we need to be cautious when we use rituximab in a patient, and we are. We have very detailed conversations with patients, especially if they've not had primary series and booster, and we don't have evidence to tell you that even those people are protected, because the timing of their vaccination vis-a-vis their previous Rituxan infusion may have impact on that. And we will not have the power even with a national resource like N3C to answer those questions. But clinically, I think we are trying to be very cautious in people with incomplete immunization, in people with incomplete booster. And I know we've not addressed that in our study, but we know nationally and internationally what's happening with immunocompromised patients who have incomplete vaccination when they get COVID. So you put that anecdotal information together. Clinically, we are using this medication, but with great caution. And I think we really need to find if we can have a study that tells the best timing of rituximab, since their last vaccine. Should their last booster be no more than X months before the rituximab for them to have the best outcome? So we need those studies to be done. So I know I've gave you a very long answer to your question, but I think there's so much unknown that caution is key, shared decision-making is key, but in my mind, doing more sophisticated, elegant studies that account for the variant, the vaccination in detail, and the new COVID treatments in detail, while you look at this risk, can really truly identify attributable risks to this medication and then guide us when to time it. Because we cannot go to a place where we don't use it, because our patients need it. Most of them are on this because they failed many or all other options, and their RA being active is also probably a risk factor for bad outcomes, both cardiovascular and otherwise. So I truly feel we need more data. Until then, we're going to be more cautious than we should be with data, and that's how, at least the way I'm practicing right now.
No, I love that explanation, because you're right. There's so much data. There's so much information we don't know, and to be able to, and patients on RA don't get on rituximab unless they've usually been through a lot of other things and had difficult time with it. So they are probably a different group of rheumatoid arthritis patients.
Right, and one would ask the questions such as, what about people who need rituximab but are on 10 milligram of prednisone? What about people who have had a COVID infection in the last 6 months but had a full booster? What about people who are more than 65? What about people who have multiple comorbidities? What about people who for some reason or other cannot have booster or did not take booster? So there's tons of questions we need to answer. I think another thing to keep in mind is that as much as we're all getting tired of COVID-19 pandemic and the vaccinations, which is I think a huge advance in treatment of COVID, which has turned this killer illness from being devastating, continuously devastating, to something that we can maybe handle. I mean, there's still the loss of life is immense. I think we cannot come to a point where we say, well, there's been a lot we already know about COVID.
Right.
We don't need to see another 50 publications on COVID, and we already know everything about our conditions and our medications. I don't think that's true. And I think we've learned a lot. I think we've grown a lot, but I think that the virus itself keeps on transforming and keeps on offering us challenge despite all the vaccination and guidance we have, that there's still hundreds of people in every country and thousands of people across the globe that continue to die, and some of these are our patients. And if we can figure out a way to use our medications even a tad bit more safely with more data available to us rather than going by intuition, I think we would have done a big service to our patients.
Well, thank you so much for your time today. I very much enjoyed talking to you, and congratulations on the study.
Thank you.
For the complete article, please visit www.sciencedirect.com/journal/seminars in arthritis and rheumatism. If you're interested in more video content from seminars in arthritis and rheumatism, please hit the subscribe button. Thanks for watching.